Welcome to Pediatric Case Review. Today's lecture is a comprehensive case-based review of pediatric pleural effusion, covering 16 carefully designed clinical cases across the full spectrum of this important topic. We will explore the most common causes in children, physical examination findings, pathophysiology, imaging interpretation, pleural fluid analysis, and evidence-based management strategies following both British Thoracic Society and Infectious Diseases Society of America guidelines. This lecture is designed for general pediatric physicians and trainees. Let us begin. Case 1. A 4-year-old boy presents to the emergency department with a 5-day history of high fever with temperature 39.2 degrees Celsius, productive cough with purulent sputum, progressive respiratory distress and tachypnea, and decreased appetite and irritability. On physical examination, respiratory rate 45 breaths per minute, heart rate 120 beats per minute, oxygen saturation 92% on room air, decreased breath sounds on the right side, dullness to percussion over the right lower chest, and reduced chest expansion on the right. Chest X-ray shows a large right-sided opacity with obliteration of the costophrenic angle and a visible meniscus sign. What is the most likely diagnosis? Option A, bronchiolitis with respiratory failure. Option B, pneumonia with parapneumonic effusion. Option C, congenital diaphragmatic hernia. Option D, pulmonary contusion from trauma. The correct answer is option B, pneumonia with parapneumonic effusion. This is the most common cause of pleural effusion in children, and this case represents the classic presentation: fever, productive cough, and respiratory distress in a young child, combined with the characteristic chest X-ray findings. The meniscus sign, which is the curved upper border of the fluid on the radiograph, and obliteration of the costophrenic angle both confirm fluid accumulation in the pleural space. Parapneumonic effusion results when infection in the adjacent lung triggers an inflammatory response that increases pleural capillary permeability, allowing protein-rich fluid to leak into the pleural space. According to British Thoracic Society guidelines from 2005, this remains the most frequent pleural pathology requiring management in pediatric practice. Case 2. A 7-year-old girl presents to the clinic with a 3-week history of intermittent low-grade fever, night sweats requiring clothing changes, progressive weight loss of 3 kilograms over 3 weeks, and mild shortness of breath on exertion. On examination, she appears mildly ill but alert, with dullness to percussion over the left lower chest, decreased breath sounds on the left side, and no acute respiratory distress. Chest X-ray reveals a left-sided pleural effusion with mild mediastinal shift. What is the most likely diagnosis? Option A, acute bacterial empyema. Option B, malignant pleural effusion. Option C, tuberculous pleuritis. Option D, congestive heart failure. The correct answer is option C, tuberculous pleuritis. The subacute presentation over 3 weeks with the classic constitutional triad of fever, night sweats, and progressive weight loss is the hallmark of tuberculous pleuritis. This is distinguished from acute bacterial empyema, which presents acutely over days with high fever and rapid deterioration. Key diagnostic highlights. Pleural fluid analysis typically shows lymphocytic predominance. Adenosine deaminase levels are typically elevated above 40 units per liter, and the condition is more common in tuberculosis endemic areas. An important clinical pearl: tuberculous pleuritis can present without active pulmonary disease on chest X-ray, making pleural fluid analysis absolutely crucial for diagnosis. Never dismiss this diagnosis based on a normal-looking lung parenchyma. Case 3. A 2-year-old boy develops respiratory distress 24 hours after corrective surgery for tetralogy of Fallot. On examination, he has decreased breath sounds on the right side with dullness to percussion. Chest X-ray reveals a large right-sided effusion. Thoracentesis is performed and the pleural fluid appears milky white. Laboratory analysis shows a triglyceride level of 130 milligrams per deciliter. What is the most likely diagnosis? Option A, postoperative empyema. Option B, hemothorax. Option C, chylothorax. Option D, transsudative effusion. The correct answer is option C, chylothorax. Postoperative chylothorax is a known and well-recognized complication of cardiac surgery, particularly procedures involving the thoracic duct or its tributaries near the great vessels. The diagnosis is confirmed by the combination of milky white appearance and a triglyceride level above 110 milligrams per deciliter. This patient's level of 130 milligrams per deciliter clearly exceeds this diagnostic threshold. It is critical to distinguish true chylothorax from pseudochylothorax. In chylothorax, triglycerides exceed 110 milligrams per deciliter, cholesterol is below 200 milligrams per deciliter, chylomicrons are present, and cholesterol crystals are absent. In pseudochylothorax, the pattern is reversed, with high cholesterol, cholesterol crystals present, and triglycerides below 50 milligrams per deciliter. Case 4. A 5-year-old boy is brought to the emergency department after falling from his bicycle onto the pavement. He landed on his right side and is now complaining of sharp chest pain that worsens with deep breathing. History: high-energy fall approximately 2 hours ago. Immediate onset of right-sided chest pain. Pain rated 7 out of 10, sharp and stabbing in nature, increasing with inspiration and movement, and no loss of consciousness during the fall. On examination: uncomfortable and splinting right chest, decreased breath sounds over right lower chest, dullness to percussion on the right side. Computed tomography of the chest shows right-sided pleural effusion with no visible lung laceration. Pleural fluid appears bloody on thoracentesis. Vital signs show heart rate 110 beats per minute, respiratory rate 28 breaths per minute, blood pressure 95 over 60 millimeters of mercury, and oxygen saturation 94% on room air. What is the most likely diagnosis? Option A, empyema. Option B, chylothorax. Option C, malignant effusion. Option D, hemothorax. The correct answer is option D, hemothorax. Hemothorax is defined by the presence of blood in the pleural space, with the pleural fluid hematocrit measuring at least 50% of the peripheral blood hematocrit. This threshold is essential to memorize because it distinguishes true hemothorax from a blood-tinged effusion. Trauma is the most common cause in pediatric patients, often resulting from chest wall injury or small vessel damage. The key clinical features are chest pain and shortness of breath following trauma, bloody pleural fluid on thoracentesis, and potentially signs of hypovolemia in severe cases. In this case, the combination of high-energy trauma, right-sided landing, bloody fluid, and a computed tomography scan showing effusion without lung laceration is classic for traumatic hemothorax from small vessel injury. Case 5. A 3-year-old boy presents with a 3-day history of fever and cough. Parents report decreased activity and poor feeding. Physical examination reveals decreased chest expansion on the right side. The examiner notes specific findings during chest percussion and auscultation. Chest X-ray shows opacity in the right lower lobe with blunted costophrenic angle. Which physical examination finding is most specific for pleural effusion? Option A, tachypnea and increased respiratory rate. Option B, decreased or absent breath sounds over the affected area. Option C, dullness to percussion over the effusion. Option D, intercostal retractions and accessory muscle use. The correct answer is option C, dullness to percussion over the effusion. Dullness to percussion is the most specific physical sign of pleural effusion. The mechanism is straightforward. Fluid accumulation compresses the underlying lung tissue and replaces air-filled spaces, changing the percussion note from resonant to dull or flat. Additional signs that accompany pleural effusion include decreased tactile fremitus over the effusion, reduced or absent breath sounds, and decreased chest wall movement on the affected side. The other options are nonspecific. Tachypnea and retractions occur in many respiratory conditions, and decreased breath sounds can also result from consolidation or collapse. A practical examination tip: start percussion from normal areas and work toward the suspected effusion to appreciate the contrast between resonant and dull notes. Case 6. A 6-year-old girl presents to the emergency department with a 4-day history of fever and cough. On examination, she has decreased breath sounds on the left side with dullness to percussion. Chest X-ray confirms a moderate left-sided pleural effusion. During the physical examination, you notice that the child consistently lies on her left side, which is the affected side, and appears uncomfortable when asked to change positions. She has developed a mild left thoracic scoliosis that was not present in previous medical records from 6 months ago. The child's vital signs show mild tachypnea and low-grade fever. She appears alert but slightly irritable when moved. What is the most likely significance of the patient lying on her affected side with new-onset scoliosis? Option A, indicates underlying malignancy. Option B, suggests development of trapped lung. Option C, represents compensatory postural changes due to pleuritic pain. Option D, shows progression to chronic empyema. The correct answer is option C, compensatory postural changes due to pleuritic pain. When a child lies on the affected side, this is called splinting, a protective behavior that limits chest wall movement and reduces the friction and pain from inflamed pleural surfaces. Lying on the affected side compresses the pleural space and reduces painful movement. The mild scoliosis seen in this case is a common secondary finding due to pain and discomfort. It is a pain-related response, not a structural spinal abnormality, and it resolves completely once the underlying effusion is treated. This is an important clinical pearl. Do not misinterpret new-onset scoliosis in a febrile child as a primary spinal problem. Always evaluate for an underlying pleural or pulmonary cause. Protective posturing and pain-related scoliosis together are reliable signs of pleuritic chest pain. Case 7. A 1-year-old infant with pneumonia develops pleural effusion during hospitalization. The infant initially presented with fever, cough, and respiratory distress. Chest X-ray confirmed right lower lobe pneumonia. On day 3 of treatment, repeat imaging shows a new pleural fluid collection. What is the primary pathophysiological mechanism responsible for pleural fluid accumulation in this case? Option A, increased capillary permeability and inflammation. Option B, decreased oncotic pressure. Option C, lymphatic obstruction. Option D, increased hydrostatic pressure. The correct answer is option A, increased capillary permeability and inflammation. In parapneumonic effusions, bacterial infection triggers an inflammatory cascade that increases pleural capillary permeability, allowing fluid, proteins, and inflammatory cells to leak into the pleural space. The key cytokines involved are interleukin-1, interleukin-6, and tumor necrosis factor alpha, released by mesothelial cells lining the pleural surface. This mechanism distinguishes exudative from transsudative effusions. Decreased oncotic pressure, such as in hypoalbuminemia or nephrotic syndrome, and increased hydrostatic pressure, such as in heart failure, produce transsudative effusions because the pleural capillaries remain intact. The inflammatory process of infection is precisely what makes parapneumonic effusions exudative rather than transsudative, and this distinction is clinically important for both diagnosis and management. Case 8. A 5-year-old boy with empyema develops thick pleural fluid with septations visible on chest ultrasound. The fluid appears more viscous than initially, and imaging shows multiple compartments that do not communicate freely. Laboratory analysis reveals increased white cell count and fibrinous material. What biological process is primarily responsible for this progression? Option A, lymphatic obstruction and chyle accumulation. Option B, fibrin deposition and loculation formation. Option C, increased hydrostatic pressure from heart failure. Option D, simple transudation from vascular congestion. The correct answer is option B, fibrin deposition and loculation formation. This case illustrates the progression from the exudative stage to the fibropurulent stage of pleural infection. Neutrophil activation triggers the coagulation cascade, leading to fibrin deposits that create thick septations dividing the pleural space into separate compartments or loculations. These loculations prevent spontaneous drainage and are associated with poor prognosis if untreated. Understanding the 3 stages of pleural infection is essential. Stage 1 is the exudative stage with thin, free-flowing fluid. Stage 2 is the fibropurulent stage with thick, septate fluid, as in this case. Stage 3 is the organizational stage with fibrous peel formation. The underlying pathophysiology is increased procoagulant activity combined with decreased fibrinolysis, both of which promote septation formation and loculation. Case 9. A 4-year-old girl presents to the emergency department with a 3-day history of fever, cough, and increasing shortness of breath. Physical examination reveals decreased breath sounds and dullness to percussion on the right side. However, the initial chest X-ray appears normal with no obvious signs of pleural effusion. The attending physician suspects pleural effusion despite the normal radiograph. Which imaging modality is most appropriate as the next step to confirm the diagnosis? Option A, computed tomography scan of the chest. Option B, magnetic resonance imaging of the thorax. Option C, bedside chest ultrasound. Option D, positron emission tomography scan. The correct answer is option C, bedside chest ultrasound. Bedside chest ultrasound is the first-line imaging modality for suspected pleural effusion. There are several compelling reasons for this. First, it is radiation-free and immediately available at the bedside. Second, it has superior detection of loculations and septations compared to chest X-ray. Third, it provides real-time guidance for drainage procedures, reducing complications. Fourth, it can detect as little as 50 milliliters of pleural fluid, compared to approximately 200 milliliters needed for chest X-ray visibility. Fifth, it can differentiate between free-flowing and loculated fluid, guiding management decisions. British Thoracic Society guidelines specifically recommend ultrasound over computed tomography for initial assessment and drainage guidance in pediatric pleural effusion. Computed tomography should be reserved for cases where ultrasound is inconclusive or when anatomical details are needed. Case 10. A 6-year-old boy with a large pleural effusion requiring thoracentesis has the following pleural fluid results: protein 4.5 grams per deciliter, lactate dehydrogenase 800 units per liter, glucose 40 milligrams per deciliter, and appearance turbid in yellow-green. Based on these biochemical parameters, how would you classify this pleural effusion? Option A, transudate. Option B, exudate. Option C, chylous effusion. Option D, hemorrhagic effusion. The correct answer is option B, exudate, based on Light's criteria. Each parameter in this case points clearly to an exudative process. The protein of 4.5 grams per deciliter exceeds the exudate threshold of 2.9 grams per deciliter. The elevated lactate dehydrogenase of 800 units per liter confirms active inflammation. The low glucose of 40 milligrams per deciliter suggests a complicated effusion such as empyema, tuberculous pleuritis, malignancy, or esophageal rupture. The turbid yellow-green appearance is consistent with parapneumonic effusion or early empyema. Light's criteria for exudate in pediatric patients require pleural fluid protein above 2.9 grams per deciliter, protein ratio of pleural fluid to serum above 0.5, lactate dehydrogenase ratio above 0.6, or pleural fluid lactate dehydrogenase above 2/3 the upper limit of normal. A key clinical pearl: pleural fluid glucose below 60 milligrams per deciliter always suggests a complicated or serious etiology. Case 11. A 3-year-old boy presents with milky pleural effusion following cardiac surgery. He is on postoperative day 2 after tetralogy of Fallot repair. He has respiratory distress with decreased breath sounds on the right side, and chest X-ray shows moderate right-sided pleural effusion. Pleural fluid analysis shows appearance milky white and opalescent, triglycerides 120 milligrams per deciliter, cholesterol 180 milligrams per deciliter, and protein 3.8 grams per deciliter. Based on these pleural fluid lipid analysis results, what is the most likely diagnosis? Option A, pseudochylothorax. Option B, empyema with high lipid content. Option C, chylothorax. Option D, transudative effusion. The correct answer is option C, chylothorax. The diagnostic criteria for chylothorax require triglyceride level above 110 milligrams per deciliter, cholesterol below 200 milligrams per deciliter, presence of chylomicrons, and milky appearance. This patient meets all criteria. Triglycerides of 120 milligrams per deciliter is above the threshold. Cholesterol of 180 milligrams per deciliter is below 200, and the appearance is milky white. The post-cardiac surgery context is a strong supporting factor. The triglyceride level is the key discriminator between chylothorax and pseudochylothorax. In pseudochylothorax, triglycerides are low below 50 milligrams per deciliter, cholesterol is high above 200 milligrams per deciliter, and cholesterol crystals are present. First-line treatment is a medium-chain triglyceride diet because medium-chain triglycerides bypass the lymphatic system by absorbing directly into the portal circulation, significantly reducing chyle production and thoracic duct flow. Case 12. A 7-year-old girl from a tuberculosis endemic area presents with a 3-week history of low-grade fever, night sweats, and weight loss. Physical examination reveals dullness to percussion over the left lower chest. Chest X-ray shows a moderate left-sided pleural effusion. Thoracentesis yields clear, straw-colored fluid with lymphocytic predominance at 85% lymphocytes. Bacterial cultures of the pleural fluid are negative after 48 hours. What laboratory test would be most helpful in confirming tuberculous pleuritis? Option A, C-reactive protein level. Option B, erythrocyte sedimentation rate. Option C, procalcitonin level. Option D, adenosine deaminase level. The correct answer is option D, adenosine deaminase level. Adenosine deaminase levels in pleural fluid are elevated in almost all patients with tuberculous pleuritis. A level above 40 units per liter has a sensitivity of 85 to 95% and a specificity of 85 to 90% for tuberculous pleuritis. This makes it far superior to the alternatives in this clinical context. C-reactive protein and erythrocyte sedimentation rate are nonspecific inflammatory markers that cannot distinguish tuberculosis from other infectious causes. Procalcitonin is elevated in bacterial infection, but not reliably in tuberculosis. Adenosine deaminase is also more reliable than pleural fluid culture, which is positive in only 20 to 40% of tuberculosis pleuritis cases. The optimal diagnostic approach combines adenosine deaminase above 40 units per liter, lymphocytic predominance in the fluid, and appropriate clinical suspicion based on exposure history and endemic area residence. Case 13. A 5-year-old boy presents to the emergency department with a 3-day history of high fever, productive cough, and progressive respiratory distress. On examination, he appears anxious and is using accessory muscles of respiration. Vital signs show temperature 39.2 degrees Celsius, heart rate 140 beats per minute, respiratory rate 45 breaths per minute, and oxygen saturation 88% on room air. Physical examination reveals decreased breath sounds and dullness to percussion over the entire right hemithorax. Chest X-ray demonstrates a massive right-sided pleural effusion with complete opacification of the right lung field and mediastinal shift to the left. What is the most appropriate immediate first-line treatment for this patient? Option A, intravenous antibiotics alone and close monitoring. Option B, chest tube drainage with pleural fluid analysis. Option C, immediate thoracotomy and surgical decortication. Option D, needle thoracentesis for diagnostic sampling only. The correct answer is option B, chest tube drainage with pleural fluid analysis. For large effusions or those causing respiratory compromise, chest tube drainage is the indicated first-line treatment. Antibiotics alone are insufficient for significant parapneumonic effusions because the fluid acts as a protected compartment where antibiotic penetration is poor and bacteria can persist. Early drainage prevents prolonged illness and reduces hospitalization duration. Ultrasound guidance significantly improves safety and success rates and is strongly recommended. Fibrinolytic agents are added secondarily only if loculations develop after chest tube insertion. Immediate thoracotomy is reserved for cases that fail medical and fibrinolytic therapy. According to both Infectious Diseases Society of America 2024 and British Thoracic Society 2005 guidelines, pleural drainage is recommended for moderate effusions with respiratory distress and for all large parapneumonic effusions. Case 14. A 4-year-old girl was admitted with pneumonia and developed a large right-sided pleural effusion. A chest tube was inserted 48 hours ago with initial good drainage of 400 milliliters. However, follow-up ultrasound today shows multiple thick septations and loculated fluid pockets. The chest tube output has decreased to less than 50 milliliters in the past 24 hours, and the child continues to have fever and respiratory distress. What is the most appropriate next step in management? Option A, remove the chest tube and start oral antibiotics. Option B, insert a second chest tube on the opposite side. Option C, administer intrapleural fibrinolytic therapy. Option D, proceed immediately to surgical decortication. The correct answer is option C, administer intrapleural fibrinolytic therapy. Intrapleural fibrinolytics are recommended for complicated parapneumonic effusions with thick fluid and loculations after chest tube insertion, exactly as described in this case. These agents work by breaking down fibrin deposits, dissolving septations, restoring free fluid flow, and preventing the need for surgical intervention. According to British Thoracic Society guidelines, the standard agent is urokinase, dosed at 40,000 units in 40 milliliters of saline for children 1 year and older, or 10,000 units in 10 milliliters of saline for children under 1 year, given twice daily for 3 days totaling 6 doses, with a 4-hour dwell time per dose. The decision algorithm is loculated effusion after chest tube, assess drainage. If poor drainage with septations, then start fibrinolytics. Monitor response over 72 hours, and if no improvement, then consider surgery. Recent Infectious Diseases Society of America evidence suggests tissue plasminogen activator alone is as effective as combined tissue plasminogen activator plus deoxyribonuclease therapy. Case 15. A 2-year-old boy develops respiratory distress 48 hours after cardiac surgery for tetralogy of Fallot repair. Initial chest tube drainage produces 800 milliliters of milky fluid daily. Laboratory analysis confirms chylothorax with triglyceride levels of 150 milligrams per deciliter. The child is stable but requires ongoing nutritional support to promote healing and reduce calproduction. What is the first-line nutritional intervention to reduce thoracic duct flow and promote healing? Option A, total parenteral nutrition. Option B, medium-chain triglyceride diet. Option C, octreotide therapy. Option D, complete fasting for 72 hours. The correct answer is option B, medium-chain triglyceride diet. A medium-chain triglyceride diet is the first-line nutritional intervention for chylothorax management in pediatric patients. The mechanism is elegant and important to understand. Long-chain triglycerides are absorbed from the intestine, form chylomicrons, travel through the lymphatic system and thoracic duct, and enter the systemic circulation. This flow through the thoracic duct is what produces chyle output from the leak. Medium-chain triglycerides bypass this entire pathway entirely. They are absorbed directly from the intestine into the portal circulation and then to the liver, without entering the lymphatic system at all. This significantly reduces thoracic duct flow and allows the lymphatic leak to heal naturally, while the child maintains adequate nutrition. A medium-chain triglyceride diet should be initiated within 48 hours of diagnosis for optimal outcomes and reduces chyle output by up to 80% in most pediatric cases, avoiding the need for total parenteral nutrition in the majority of patients. Case 16. A 6-year-old boy presents to your clinic with a 3-month history of persistent shortness of breath and reduced exercise tolerance. He had been hospitalized 8 months ago for emphysema, treated with chest tube drainage and antibiotics. His mother reports he has not returned to his previous activity level. On examination, decreased chest expansion on the right side and reduced breath sounds over the right lower lobe. A recent chest X-ray shows pleural thickening with blunting of the right costophrenic angle. What is the most likely long-term complication in this patient? Option A, recurrent pneumonia. Option B, bronchiectasis. Option C, trapped lung syndrome. Option D, pulmonary hypertension. The correct answer is option C, trapped lung syndrome. Trapped lung occurs in the organizational stage of pleural infection when fibrous deposits form a thick pleural peel that encases and restricts the lung, preventing it from fully expanding. This results in chronic shortness of breath and reduced exercise tolerance, reduced chest wall movement on the affected side, and decreased breath sounds over the restricted area. Computed tomography scan confirms the presence of a thickened fibrous pleural cortex encasing the lung parenchyma. The definitive treatment requires surgical decortication, where the fibrous peel is physically removed to allow the lung to re-expand. This case illustrates a critical clinical pearl. Early and adequate treatment of pleural infections in children is essential to prevent progression through the 3 stages of infection and avoid the serious long-term complication of trapped lung syndrome. Are you looking for a structured way to access all of our pediatric case-based video lectures in one place? Our pediatric case review community gives you complete access to organized learning resources that will transform how you study pediatrics. All video lectures are organized by medical system, so you can navigate the entire library efficiently and study by topic. Complete access to all presentation slides is available as downloadable images, allowing you to read through and practice all questions offline at your own pace. We also provide comprehensive case question banks and high-quality content for rapid review. If you are ready to join and want to know the subscription details, simply comment below this post, and we will message you directly with all the information you need. And that brings us to the end of today's comprehensive lecture on pediatric pleural effusion. Let us review the 4 most important takeaways from everything we have covered. First, early recognition through clinical presentation and physical examination is crucial for optimal outcomes. Always look for the triad of dullness to percussion, decreased breath sounds, and reduced chest expansion. Second, ultrasound-guided diagnosis and management reduces complications and improves patient care. Bedside ultrasound detects fluid earlier than chest X-ray and guides safe drainage. Third, timely intervention with appropriate drainage and targeted therapy shortens hospital stays. Do not delay chest tube insertion for large or symptomatic effusions. Fourth, understanding pathophysiology guides treatment decisions across the full spectrum from simple effusions to complex empyema with loculations requiring fibrinolytic therapy. If you found this lecture valuable, please follow the Pediatric Case Review channel for more comprehensive case-based education. If you have questions about pleural effusion management or suggestions for future topics, leave a comment below and we respond to every question.